You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 19th, 2020. This week, COVID, corticosteroids, coronary artery calcium, SGLT2 inhibition, and a new chemical for heart failure. First, a brief update on COVID. In the United States, the rate of growth of cases is about 1.10x, and that's about flat. There's 2.2 million cases here in the U.S. The deaths here in the United States last week were 115,000, and this week they are 120,000. The rate of rise is about 1.04x, and that's steady. The big news is that there are increases in cases in the west and the south part of this country. As best I can tell, hospitalizations and deaths have not increased in these states, but given that the COVID disease process takes weeks, these changes might be coming. The spike in cases coincides with both the relaxing of restrictions and the beginning of the protests, so I think it's pretty much expected. Internationally, Brazil, Mexico, and now India look very worrisome. But there was big news in COVID-19. And that is a trial called the Recovery Trial, which was an RCT from University of Oxford researchers that began in March, and it included about 11,500 patients with COVID from 175 NHS hospitals. On June 8th, recruitment in the dexamethasone arm was halted by the Safety Monitoring Board because of efficacy. About 2,100 patients received dexamethasone and 4,300 controls. Overall, dexamethasone reduced the 28-day mortality rate. Mortality by 17%, hazard ratio 0.83, and the p-value was super low. Now, this effect was greatest in sicker patients with a 35% reduction in mortality in ventilated patients, 20% reduction in patients on oxygen, and no benefit in patients who did not require ventilatory support. That relative risk reduction corresponded to an absolute risk reduction of 12% in patients on the vent. That's an NNT of 8. Now, of course, the reason that modest relative risk reductions in the range of 30% translate to such huge absolute risk reductions or low NNTs is because the risk of dying once on a vent is so high at 41%. Compare that to most cardiac trials, which have lower rates of events. So a 30% relative risk reduction of, say, a 5% rate of outcomes is quite small. Now, this data comes from a press release. The authors say a paper is forthcoming in a week or so. But the debate on social media and Twitter was very interesting. Some prominent, super prominent public intellectuals pushed back hard on the notion of clinical medicine by press release. Some even said that we should not change practice without a paper, or at least a preprint. But I strongly, strongly disagree with that. Yes, we surely need to study the paper when it comes out. This information, however, I think is practice changing, and it's different from many press releases from pharma. First of all, the authors here have a published trial protocol. The authors are respected researchers with no financial conflict of interest, as dexamethasone costs nearly nothing. Third, given the well-described inflammatory response of COVID, especially later in the course, the inflammation-suppressing mechanism of action of dexamethasone is highly plausible. Fourth, mortality is a bias-free endpoint. Next, the p-values here suggest the chance of a type 1 error is very low. And the downsides of this drug are minimal. Remember, we hand out dose packs of steroids, often for flares of gout. Thus, we should hardly worry about giving it to a patient who's super sick with later stage COVID. I do have a serious question to my ICU colleagues. This is a caveat. Why do we see such dramatic results in this case whereas previous studies of corticosteroids in ICU settings have been inconclusive. The take-home message here requires two parts of your brain. There's the patient and the pragmatic clinician part of the noggin that says, give dexamethasone to a patient requiring oxygen or on a vent. The scientific parts of our brain say, let's see the paper, and given the prior lack of evidence for steroids in the ICU, perhaps we should have a confirmatory trial. Now, the final comment before heading to cardiology is that in the last 5 or 6 months, there have now been 8.5 million cases of COVID worldwide, and sadly, we have only a handful of RCT results. So I hope one thing that comes from this crisis is a way to cut through the bureaucracy of trials so that it's easier to randomize patients. And I know that we're not going to see the U.S. moving to an NHS or Canadian or Scandinavian healthcare system, but one huge advantage of those systems is the ability to do vital, pragmatic research such as this. Next topic is coronary artery calcium. Now, a French study presented at the diabetes meeting suggested that CAC scoring may be beneficial in patients with diabetes and high cardiac risk. But almost everything about this study is misguided, and I'm going to discuss the problems not to be mean or to attack the authors, but rather to frame what we know about heart disease in light of the recent ischemia trial findings. The first thing to say is the researchers' aim was to test various criteria to select asymptomatic patients with diabetes to be screened for silent myocardial ischemia. Why would you even look for silent myocardial ischemia? Last week I discussed the ischemia trial, and this huge study included only patients with ischemia, 41% of which were diabetics. That trial showed unequivocally that revascularization did not reduce heart outcomes in patients treated with optimal medical therapy, and this, my friends, is only the first-order thinking. I think we can go deeper to second-order thinking. And second-order thinking from ischemia and courage and buried 2D is that the indiscriminate search for ischemia seems misguided. Namely, if revascularization of focal stenoses in stable patients does not reduce MI or death, why are we looking for them? Why not just think of atherosclerotic vascular disease as a systemic disease that should be treated with systemic therapies like therapeutic lifestyle interventions, statins, maybe icosapent ethyl, and in diabetics, SGLT2 inhibitors? Now, the second issue with this study, the authors look at about 400 patients with type 2 diabetes and multiple cardiac risk factors, and they want to know if coronary artery calcium screening helps in the search for silent ischemia. And they found coronary artery calcium greater than 100 in about 43% of patients. 1 in 10 had silent ischemia. So that turned out with their cohort to be about 40 patients, and 11 of these patients ended up with revascularization. Now, we don't know how many of these revascularization procedures were bypass surgery for left main, but it's likely most were just PCI, which we know from ischemia does not reduce outcomes. And since these patients were asymptomatic, they could not have had angina relief. So in the end, 11 of 40 patients ended up with non-beneficial procedures. Now, the third point here is that the authors then tested the performance of coronary artery calcium versus other criteria, such as using nuclear perfusion imaging or using the presence of severe peripheral vascular disease in discriminating for silent ischemia. And they did some sort of statistics that's difficult to tell from the abstract. But then they conclude that the algorithm that included CAC was the most cost-effective. And they recommend screening only high-risk diabetic patients who have peripheral artery disease or a high calcium score. Now, that kind of conclusion boggles my mind because I don't understand how coronary artery calcium changes anything. If you have a high-risk patient with diabetes, you're going to maximally medically manage the person, whether they have calcium or no calcium. Coronary artery calcium screening simply tempts you to reduce medical therapy when it's low and perform unnecessary angiography and PCI when it's high. The authors say coronary artery calcium is cost-effective, but I ask effective for what? In medicine, there are simple rules, and one of them is if a test will not change management, do not do it. Next topic is a trial called VERTIS, V-E-R-T-I-S. This was presented at the virtual ADA meeting, and it's a large cardiovascular outcomes trial. Patients with type 2 diabetes with heart disease were randomized to 2 doses of the SGLT2 inhibition drug called ertugliflozin, which I have not seen used much in clinical practice, but was FDA approved in 2017 and manufactured by Merck. This was a placebo-controlled trial. Actually, Vertis is a suite of trials, and this was the mandated cardiovascular outcomes trial. Now recall that since 2008, all new drugs for type 2 diabetes have to have a cardiovascular outcomes trial. And previous studies of the drug have shown that it has typical SGLT2 effects, including modest reductions of hemoglobin A1C, weight loss, and blood pressure reductions. Vertis began enrolling around 2013 and 2014, and this was before the results of EMPA-REG, CANVAS, and DECLARE were posted. This was a global RCT of about 8,200 patients with approximately 2,700 patients in 3 arms, placebo, ertugliflozin 5, and erta 15. The primary endpoint was a composite of MACE, cardiovascular death, and stroke, and the follow-up was about 3.5 years. The results, both arms had an 11.9% rate of events. The hazard ratio of 0.97 had an upper bound of 1.11. This analysis was non-inferiority, and the margin was set at 1.3, so it easily met non-inferiority. The individual components of the MACE did not come close to differing. A key secondary endpoint of cardiovascular death or heart failure hospitalization showed a 12% relative risk reduction with the drug, but it did not meet significance. And the statistical plan had this as the first in hierarchical testing, and since it did not meet significance, other secondary endpoints could not be called significantly different. But the next endpoint the authors showed, which was heart failure hospitalizations, was reduced by 30% with the drug. Now, this p-value was nominally significant, but it cannot be considered definitive due to the way the statistical plan was. Now, this whole statistical thing sounds complicated, but the way I understand it is that if you have oodles of secondary endpoints, the odds that one is going to be positive by chance is about 1 in 20. So the way to get around this sort of garden of forking paths is to test them in hierarchical order. There was also a renal protection part of this trial. SGLT2 inhibitors have renal protection properties, and so the authors measured a renal composite endpoint, which included renal death, dialysis, or doubling of the creatinine, and the hazard ratio here of 0.81 trended better with the drug, but did not reach statistical significance. I'm going to analyze this trial as an outside observer, but what I see is that the drug has class effects, for sure, weight loss, blood pressure reduction, and favorable effects on hemoglobin A1C, but it did not reduce cardiovascular outcomes. That's important because we already have drugs that do. Empagliflozin and canagliflozin do reduce cardiovascular outcomes. Canagliflozin in the Credence trial clearly improved renal outcomes. And in DAPA heart failure, dapagliflozin was hugely beneficial in patients with heart failure with reduced ejection fraction. So why at this point do we need another SGLT2 inhibitor? Why do we use this drug over others in the class? But wait a second. What do people do when their chosen drug underperforms relative to its competitors? One thing you do is a meta-analysis of the trials of this class, and then you can say the non-significance of these findings were in line with other drugs. My friends, I'm not buying this. I am highly suspicious that this meta-analysis is an attempt to detract from the disappointing findings. Go look at the meta-analysis slides. I looked at them. The forest plots of the trials show that, yes, the confidence intervals do overlap with each other, but all the other trials are solidly to the left of the null, favoring the active drug. But the data from Vertis shows that ertugliflozin hovers that null line. And maybe this is just bad luck for Merck. I can't tell from the slides what the power calculation was, but if you can't show benefit in a trial of 8,000 high-risk patients with established heart disease and diabetes, but other drugs have, I'm not sure why this one would pass muster and be used. My take is that these drugs are not so much diabetes drugs, but reducers of bad cardiac and renal outcomes, and this is what matters. Final topic today is on a novel chemical for heart failure. The drug is called vericiguat. In an RCT of patients with heart failure and preserved ejection fraction, that was presented at the Heart Failure Association meeting. Vericiguat, which is a novel oral soluble guanylate cyclase stimulator, did not improve patient quality of life or walking time on a 6-minute walk test. Now, this was a trial of almost 800 patients with HFpEF. It was not powered to assess outcomes, but the lack of improvement in patient-reported outcomes was surely disappointing. Previous trials, a phase 2 trial called Socrates Preserved, did show that vericiguat may have some modest benefits in quality of life. Now, even more disappointing from this trial was that symptomatic hypotension on the drug was more common. Now, while vericiguat did not seem to help in HFpEF, no drug really has, the chemistry and outcomes of this drug are notable. In a big trial called the Victoria trial, which was presented at the pandemic-obscured virtual ACC in March, found that the drug vericiguat improved outcomes in patients with heart failure with reduced ejection fraction. Before I tell you about the Victoria trial, let me just explain what I've learned about this new chemical. Turns out that soluble guanylate cyclase is deficient in patients with systolic dysfunction and heart failure. The drug directly stimulates soluble guanylate cyclase and it sensitizes it to endogenous nitric oxide. Now, these novel chemical actions in the heart may improve contractile function, may improve diastolic function, and the drug may have antifibrotic actions. So Victoria was a multi-center RCT in 5,000 patients with heart failure with reduced ejection fraction. The primary endpoint was a composite of CV death or heart failure hospitalizations. This study was published in the New England Journal of Medicine. Over 2.5-year follow-up, the primary endpoint was reduced by 10% in relative terms, the hazard ratio 0.90, and the p-value was 0.02. Now, like I've talked about before, the event rate was very high, so this relative risk reduction of 10% turned out to be an absolute risk reduction of 5%, but the difference was mostly driven by fewer heart failure hospitalizations. CV death was modestly lower, and the authors even wrote in a discussion that it was, quote, possibly lower. All-cause mortality did not differ. Now, while serious adverse events were similar in both arms, low blood pressure and syncope trended higher in the vericiguat arm. My take of this drug and this trial is this seems to be a really modest effect. I mean, think about it. You have a 5,000 patient trial. More than a third of these patients have a primary endpoint. P-value is 0.02, driven by a softer heart failure hospitalization endpoint, and no difference in all-cause mortality and more hypotension. I don't think vericiguat is going to be a game changer, especially in the setting of drugs like sacubitril, valsartan, and now the SGLT2 inhibitors. I mean, if the drug cost pennies, you might try it, but it's not going to cost pennies. And the other thing is, how many pills do we think our patients with heart failure are going to be able to manage? So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please consider taking the time to give us a rating or writing a review or telling a friend. It really helps other people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.